Hello and welcome back. We're here with part 4 of the NCCN guidelines on advanced stage and recurrent endometrial cancer. And part 3 went over a little bit of advanced stage, more focused on adjuvant treatment after surgical staging. But I'm coming to you after 2024 SGO, where immunotherapy was probably the highlight of the conference. And so let's go over how we're adding immunotherapy to endometrial cancer treatment. So here we are with the algorithm. We're not going to do surgical staging like we did. We are already suspecting extrauterine disease. If your patient is suitable for primary surgery and you can completely debulk them with the abdominal pelvic confined disease, then yes, surgery is key. If they have distant mets, lung, liver, something that you're not going to be able to resect, then we're going to move along to systemic therapy. So that's where we're going to go today. And so looking at the primary systemic therapy for advanced endometrial cancer, we have already gone over some of these regimens. So we have gone over carbotaxol. We talked a little bit about 209. We talked about carbotaxol, pembro in GY018. Go to part 3 if you want to hear more about that. We talked about the Ruby trial with carbotaxol, dostarlimab, again, last video. And then a couple other preferred regimens that we have yet to talk about. So today we'll talk about carbotaxol trastuzumab, and then we will go over this regimen for carcinosarcoma because it says HER2 positive uterine serous carcinoma. We'll also talk about a couple other new indications for trastuzumab that have yet to be updated in the NCCN guidelines as I have last checked. And then carbotaxol trastuzumab for carcinosarcoma. This is an ongoing trial, GY026, and we'll go through carcinosarcoma probably in the next video, but not today. Okay, so broadening this to therapy for recurrent disease, because we're talking about advanced and recurrent disease here. Recurrent disease, a lot of the regimens that we just discussed on the last slide. But then what we're going to focus on today, as I said, were immunotherapies. So coming down here, useful in certain circumstances, biomarker-directed therapy. We have Lenvatinib, and then we have pembrolizumab alone, as well as dostarlimab alone. So we're going to go over the indications for those and kind of how immunotherapy weaseled its way into endometrial cancer. I introduced this little slide on my last video, but I find it to be very helpful to visually see where each of these regimens fit with each stage. Pembrolizumab and pembro alone are not on here, but you can reference this for GY018 or Ruby in your spare time. So on to immune checkpoint inhibitors. So PD-1 is found on T cells, and PD-L1 may be found on some normal cells, but in higher than normal amounts on some types of cancer cells. And these proteins act as kind of a brake here, like here, or otherwise known as a checkpoint, hence immune checkpoint inhibitors, to keep the body's immune responses under control. When PD-L1 binds to PD-1, as shown here, it keeps the T cells from killing the PD-L1 containing cells, which include cancer cells. So anti-cancer drugs like immune checkpoint inhibitors, they bind to the PD-L1 or PD-1 and block its binding to the subsequent receptor. So this then releases the brake on the immune system and leaves the T cell to kill the cancer cells. So taking advantage of that, one fun fact that I learned today while I was prepping for this PowerPoint is, this may be intuitive to most people, but the keynote studies are all on pembro. Keytruda, Keynote. Never even thought about it, I guess. But there's your fun fact of the day if you didn't learn anything from this lecture. So Keynote 158 was a multi-cohort study with multiple disease sites, as seen here. But it included 49 patients with unresectable or metastatic MMR deficient endometrial cancer. Patients received pembrolizumab at 200 milligrams IV every 3 weeks until unacceptable toxicity or documented progression, and these patients could be treated for up to 24 months. The objective response rate was 57%, and so this was the basis for pembro alone in MSI high or deficient MMR tumors. And next we have the Garnet trial. And so the question here was the activity and safety of dostarlimab for patients with deficient MMR or MSI high tumors. Endometrial cancer was included. It was a phase 1 open label single group multi-center study, non-randomized. There were 327 participants, and the overall objective response rate was 44%, with a median duration of response that was not reached at the time of publication, but 27.7 months. No new safety signals. The most frequent immune-related adverse effects were hypothyroidism, transaminitis, and arthralgias. And I think the most important thing that we care about here is there were 143 endometrial cancer patients, and the objective response rate was 45%. So they gave 500 Q3 weeks for 4 doses and then spaced it out, increased the dose to 1,000 Q6 weeks until disease progression, discontinuation, or withdrawal. This is a similar dosing to the Ruby trial for dostarlimab, where they did 500 Q3 weeks for 6 cycles and then spaced out to Q6 weeks with increased dose of 1,000. All right, so this had set the stage for single-agent dostarlimab in deficient MMR endometrial cancer, as well as the previous trial with pembro. But you might be thinking that most endometrial cancer is microsatellite stable, probably about 75%. So now what? And well, I guess in this graph it's 70%, and I'll say later that 28% is deficient MMR or MSI high. So 25 to 30%. And I'm already giving you a peek at the answer here, unfortunately. But we then went on to Keynote, pembro, Keytruda, plus Lenvima. So Lenvatinib plus pembrolizumab in Keynote 146. This showed anti-tumor activity in patients with advanced endometrial cancer. They had prior systemic therapy. These are the criteria here. An ECOG performance status of less than 2, and they had prior systemic therapy. This was regardless of their MSI status. They were matched in different cohorts, and then they were started on 20 of Lenvatinib, and they were given 200 milligrams of pembro Q3 weeks. 49% of patients were PD-L1 positive, 37% of patients received 2 prior lines of therapy, and the primary endpoint was the objective response rate at 24 weeks. A little side note here is that Lenvatinib is a oral small molecule inhibitor of VEGF, similarly to bevacizumab, but also includes fibroblast growth factors, platelet growth factor receptors, and then KIT and RET proto-oncogenes. And then this is just a pathway here that is showing kind of where Lenvatinib works in several different areas. So VEGF, FGFR, and then EGFR, as well as this RET pathway. So in multiple areas of both the tumor cell, but then also vascular endothelial cells. Okay, so 108 patients were enrolled. The median follow-up was around 18, 19 months. The overall response rate was 38%. And among different subgroups that we listed here, it was 63% in patients who had MSI high tumors, and then 36% in patients with microsatellite stable tumors. And their grade 3 or 4 treatment-related adverse effects occurred in 66.9% of patients. So this was compelling data. Reminder, this was a phase 1b/2 trial, which then led to Keynote 775. And so this trial was comparing Lenvatinib pembro versus chemotherapy. And the chemotherapy was either doxorubicin every 3 weeks or paclitaxel weekly, 3 weeks on, 1 week off, I think. And so the progression-free survival charts are here with the proficient MMR versus all patients. And then the overall survival data is here with a breakdown between proficient MMR and overall survival. The conclusion was that the PFS and OS was higher in the Lenvatinib pembrolizumab arm compared to chemotherapy. The progression-free survival as well. One other thing about this trial, so that is how we got Lenvatinib pembrolizumab onto the NCCN guidelines. One thing to point out here, though, are the toxicities in the trial. So in 775, the adverse events of grade 3 or higher occurred in 88.9% of patients in the pembro Lenvatinib group, and then 72.7% of patients in the chemo group. So this is a very high rate of adverse events. And just of note, because now we're giving a lot of pembrolizumab, it's not broken down between pembrolizumab and Lenvatinib, so you can't necessarily say it was one or the other, but remember that the pembrolizumab causes all the itises, so basically inflammation of any part of the body, so pneumonitis, thyroiditis, hepatitis, colitis, dermatitis. There's a really, really nice ASCO immune checkpoint therapy adverse event guideline paper if you Google it, and then NCCN also has guidelines on their website. So I would encourage you, if you don't have an NCCN account, it's free and you should 100% sign up. And then Lenvima, very similarly to bevacizumab, as it has that similar mechanism of action, hypertension, fatigue, diarrhea, arthralgias, nausea, vomiting. So and of note, in this trial, multiple people needed a dose reduction of Lenvatinib, and that was accounted for in the study. So oftentimes patients will get dose reduced and worry about the efficacy of the drug, and you can point to the trial when you discuss that with them. Okay, so check and check. We have went over single agent immune checkpoint therapy as well as pembrolizumab, and just to float right back into Ruby and GY018, now that we know some of the trials that started the immunotherapy train in endometrial cancer, back to that 28% of cancers were high microsatellite instability, and we knew that monotherapy with an immune checkpoint inhibitor as a second-line therapy was efficacious in dMMR endometrial cancer. We also have this pembrolizumab trial that said that was efficacious in proficient MMR endometrial cancer. And so the thought was, could we use this with chemo in order to provide better outcomes? And I'm sure someone who studies this in the lab could give you a really, really great explanation of how these two, chemotherapy and immunotherapy, work in synergy. But from what I can tell, it increases the efficacy by targeting cancer cells through chemo and boosting the immune system's ability to fight the cancer through immunotherapy. So the chemotherapy can stimulate anti-tumor immunity and then potentiate the clinical activities of the immune checkpoint inhibitors. It's really, really very interesting, and very grateful for people in the lab who are doing work like this. Okay, and the last few slides are just on HER2 in endometrial cancer. So the first trial I want to talk to you about is Amanda Nichols-Fader phase 2 trial on serous endometrial cancer. It included primary stage 3 or 4 recurrent HER2 positive patients. They were randomly assigned to carbotaxol for 6 cycles with or without trastuzumab until progression or unacceptable toxicity. And progression-free survival was improved by 4.6 months in patients who received trastuzumab plus carbotaxol compared to those who just received carbotaxol alone. And so it did benefit patients in the primary treatment setting, as you can see here. And this was, again, just for advanced stage and recurrent. Recently, this trial was published, Destiny Pan-Tumor 02, which was a phase 2 trial on Enhertu or trastuzumab deruxtecan, which is a antibody drug conjugate. It's a HER2-directed antibody drug conjugate composed of humanized immunoglobulin G1 anti-HER2 monoclonal antibody and a tetrapeptide-based cleavable linker and a potent topoisomerase 1 inhibitor. And so this was an open label multi-center phase 2 study. It looked at the efficacy of this drug every 3 weeks in HER2 expressing solid tumors. This had to be done by IHC, and they included +2, +3 solid tumors. And as you can see here, the progression-free survival was 6.9 months, and overall survival was 13.4 months in the overall trial, with the greatest benefit observed in the HER2 IHC 3+ population. And I really like the color scheme of this table. Maybe that's why I like it so much, but I want to draw your attention to the endometrial cohort, the confirmed objective response rate. And in this cohort, greater than 75% of patients had 2 prior lines of chemo, and the response rate was 84.6% in IHC 3+. And in all patients in endometrial cancer, the median PFS was 11.1 months and 26.0 months, respectively. So this is promising as well. And like I said, is new data that came out and was talked about at Winter SGO. So hopefully we hear more about this, but not quite in the guidelines, NCCN guidelines from the last time I checked. Okay, that is it. That is all. That's enough. I will link some papers here, and if you have any questions, leave a comment. It was a little bit of a longer one, but a lot of data in here. Very exciting stuff. So I hope everyone enjoyed SGO, and I hope you find this helpful.